Thank you very much, Simon. Thank you. It's my pleasure to come and talk to you about our experience in cryotherapy. So we've only actually been carrying out this for about 5 years. So I want to share with you our experience and some of the issues. The purpose of salvage prostate cryotherapy and deep prostate cryotherapy is to achieve an ice ball temperature of minus 30 degrees Celsius or so for the entire prostate using needles that is placed in the perineum in a reverse refrigerator principle of generating coldness by decompression of gas. And you can see those needles forming ice balls, and with time, those ice cylinders merges together to involve the entire prostatic volume. Typically, the needles are freeze from the anterior-posterior aspect, and as time goes on, the ice cylinder merges, and you can see the okay, it's not that. Yeah, you can see the urethra. In the urethra, there's a urethral warming tube that keeps the urethra warm and protects it from freezing. So you can imagine that as the ice cylinder forms, it actually comes out beyond the tip of the prostate because the urethra is protected and the apical part of the prostate is protected. So there is potentially the ice ball extending beyond that of the prostate. So that's something that I'll come back to later on. And that is, of course, relevant because of the location of the sphincter. The question is, how good is this treatment? These data you see here are historical data now. Even 10 years ago, the data would suggest there are some respectable results in terms of biochemical free survival of around 50, 60, up to 70% with respectable follow-up. And in fact, it was about 3 years ago that a landmark report from Kingston, from Joe Chin's center in Ontario, published long-term follow-up data of around 187 patients. The follow-up was significant with just under 8 years, and the disease-free survival at 10 years was encouraging at 40%. Not surprisingly, a lot of the factors that are predicting the outcome to do with the tumor parameter, with PSA level, with Gleason score. I think the key point from that paper is that post-cryotherapy PSA level of under 1 is a beneficial, is a good prognostic marker. And you can see from this survival plot here that PSA level under 1 predicts a good disease-free survival outcome. But also important to note, even in the less favorable group, the biochemical free survival is actually quite significantly improved than untreated. So you can see that the at 2 years, there's just about 50% of them are disease-free. So that is an important point to make that I will come back to in terms of delaying androgen ablation treatment. End of last year, this year, Karen Ars published his data from New York. You can see that he has 3 cohorts. On your left, you will see the straightforward external beam, and the middle, the brachytherapy group. Very similar results of about over 50% of disease-free survival. Important to point out that the median time to recurrence is around 55 months, so significant delay of any potential androgen ablations. One point to make also is that on the right side, you see post-primary cryotherapy. For me, that doesn't seem like a very good result. 7 patients out of 20 patients were rendered disease-free. So I don't think salvage cryotherapy after failed cryotherapy would be a very good option. We are able to develop the service in Scotland and have been very fortunate to have support from our colleagues in Guildford through John Davis and Damien Green in Sunderland. And we have combined our cohort of 283 consecutive cases over a period of 10 years. Of those, at the time of the study, we have 42 cases within the Glasgow cohort that we obtained additional parameters during the procedures to correlate to functional outcome, which I'll come back to. One point to say in the earlier study in the William et al. Paper from Canada, majority of the tumors are in fact low grade. Only about 7 patients of the 200-odd patients were Gleason 8 or above. In our cohort, you can see that a significant proportion of some 35% are actually high grade of Gleason 8 and above. And also a significant proportion, half of a quarter, 20% of them have high PSA above 10 as well. We would treat patients up to T3A. So in the T staging, about 28% of them are T3A. So that's significant disease burden. So this is the group of patients that you would not necessarily even consider salvage prostatectomy. It's fair to say that in our cohort, we did not find increased level of PSA nor the pre-cryo Gleason score correlate to the PSA nadir. So on the right bottom here, you see the PSA level coming down after salvage cryotherapy significantly, not associated to the tumor Gleason score and PSA level. And importantly, using the William et al. Criteria, a PSA of 1 as a cutoff post-treatment was a significant factor in predicting outcome. So that's really consistent with previous results. And this is the first time we're able to show it in a multi-center cohort. What about toxicity to the treatments? And we here in red are summarizing the percentage of toxicity that we observed. These are very similar to what have been published in the previous studies. The bottom line is about 10% of the patients will develop incontinence, which is defined as using the part of one part or more. So some of them are not serious toxicities, but some are. The other point is also with lower urinary tract symptoms, which is not actually included in this table. Also some 5 to 10% developed obstructive symptoms also. So overall, there are, although well tolerated, overall there are significant proportion of patients do develop symptoms. So what we want to do is to understand whether we can predict which patients might develop toxicity. So we, during the procedure, we measure the temperature achieved in the prostate, and we measure the size of the prostate before the treatment, and also I measure the length of the ice ball. We can't measure the thickness of the ice ball because we can't see the anterior part of the ice. Just to validate our cohort of the 42 patients, we were able to demonstrate that the nadir PSA that we obtained were comparable to the entire cohort. In fact, surprisingly, the nadir PSA post-cryotherapy was very similar to the initial post-radiotherapy PSA, suggesting that it's really quite an effective treatment in that context. We measure temperature, the right lobe, the left lobe, at the end of the first cycle, at the end of the second cycle, as shown here. And these are in -degrees Celsius. We measure the gland length in millimeter, and these demonstrate here. And we measure the length of the ice ball at the end of the first cycle and the second cycle in the sagittal plane, where you can see the urethral warming tube, as demonstrated here. And then we calculate whether there is any association of these parameters to the patient's IPSS post-treatment, either as a mean or as a maximum at the peak of troublesome symptoms. And you can see that in red are the significant results. So temperature has no correlation to the toxicity in terms of maturation function. Gland length is correlated to it, and it's negative. What it means is that the shorter the prostate length, the higher the chance patient have symptoms. And the ice ball length also is correlated, and it's in a positive correlation. That means the longer the ice ball length, the higher the risk of toxicity. This is a bit cumbersome, so we actually want to simplify it. So we're simply looking at the lowest temperature achieved whichever part of the prostate, the gland length, and the longest dimension of the ice ball, whichever part of the procedure and position. And you can see again, the correlation is consistent, that the shorter the gland length, the longer the ice ball are associated with higher toxicity. The ratio between the ice ball length to the gland length is about 1.4, we think is the cutoff, but it's not statistically significant at the moment. So we will need additional case to demonstrate that predictive value. So I've shown you, we've demonstrated our multi-center cohort, PSA1 as a cutoff for outcome predictions. We demonstrate to you the feasibility of using parameter to predict outcome. Of course, we still don't know how good it is compared to other treatments and compared to the standard treatment, which is, of course, androgen ablations in this group of patients. We were very fortunate to obtain support across the UK in a number of centers. In blue are the centers that they have not previously done cryotherapy, but were keen to be involved. Our objective is to test effectively how good the treatment is in terms of cancer control or cure. The secondary objective is how safe, how well tolerated, and the side effect profiles, and importantly, the cost effectiveness analysis, because that will not only apply to cryotherapy, can apply to other salvage options. The endpoint, we didn't go for overall survival because it would be too big a study, too many patients required, but we didn't want a soft endpoint like PSA, so we decided on a distant metastatic-free survival. Various study criteria that I'm happy to talk with you after. The two issues about this study is, can we randomize? Can we convince patients to accept this study between effectively a palliation treatment and an intervention treatment? The other is, can we assure ourselves, let alone patients, the quality of the treatments carried out? And we spent a lot of effort in this. And in short, we have quality assurance procedures with an independent panel chaired by Professor Johansen in Norway. And also we have various questionnaires to understand patients' thinking, whether they accept or decline, and also have workshops to achieve that crucial equipoise from ourselves when we talk to patients. Summary. This is the only trial that you probably hear today that we failed to recruit. The study went for 18 months as a 2-year feasibility study. It was closed because of failure to recruit. 4 centers were opened, 3 managed to recruit patients. The rest were through the process of opening, due to a number of different issues, which I'll come to that in a minute. Among the 3 centers, Wirral is the top recruiting center. Out of the 11 patients approached, 4 accept. Sunderland in the second, out of 6 patients, 1 accepted. So Glasgow, we did worst. Out of 24 patients, only 2 patients accepted. Particularly in Glasgow, it's difficult because we, through the NHS Scotland, we actually have the service funded as a standard treatment option. So patients are not willing to enter randomization. The overall acceptance is 17%. Looking at the reason why patients declined, the 2 top reasons are the fact that they did not want to be randomized, and the top reason and the reasons that said to be the most important, judged by the particular question asked at the bottom, was number 4. That is, they want to have specific treatment. So randomization and the overall low number of patients referred from oncologists are the main reason we have not been able to proceed. One last point to do is that we have worked with the health economists to look at a modeling system using Markov model you heard earlier on to see how cryotherapy compared to androgen ablation. I was very surprised to find out that cryotherapy comes out more effective, cost-effective than androgen ablation at all of the domain that we look at. And the cost neutral point is at 3.5 years. So that means if you as a population, delay androgen ablation by 3.5 years, you would have saved money collectively. We also have a sub-study with functional MRI as the part of the CROP study. A lot of work going into ensuring protocols from different centers using multi-parametric MRIs. So those efforts are also now on hold because CROP has been stopped. And I would be keen to look at that as a second study. Lastly, CROP2, I think we should be looking at cohort study regardless of the treatment modality, cryotherapy, HIFU, surgery, and looking at the functional outcomes and looking at parameters that we can predict outcomes. So I want to acknowledge funding from NHS Scotland for our service. I want to acknowledge help from urology and oncology community and friends and colleagues in supporting our service in the CROP studies. I want to take this opportunity, cheeky suggestion, but I want to draw your attention to 2 major meetings in Glasgow next year. EAU, section of urological research, in October next year in Glasgow. Following on immediately would be the SIU meeting in Glasgow. So good value for money. I hope to see you in Glasgow. Thank you.